Right now, there are literally thousands of patients occupying hospital beds across the country who are perfectly healthy enough to go home.
Yeah, completely cleared by their surgeons.
Exactly. The attending physicians have signed their charts, the nurses have packed up their belongings, but they're trapped in a $3,000 a night room for one absurdly simple reason.
They just don't have a ride.
They do not have a ride. Welcome to the hidden multi-billion-dollar logistical backbone of American healthcare. We're looking at that space between a patient's front door and that hospital bed, which, honestly, we usually treat as an afterthought.
Right, we just assume you teleport to the clinic somehow.
Yeah, like Star Trek or something. But for millions of people, that physical geography is just an impassable wall.
It's the literal gap where the entire healthcare continuum can just break down. I mean, you can build a state-of-the-art, multi-million-dollar medical facility, right?
Sure.
You can staff it with the world's leading specialists, invent groundbreaking pharmaceuticals, but none of it matters if the patient cannot physically cross the threshold of the building. The geography is the first medical barrier.
The very first one. And we are pulling all our insights today from a really comprehensive grounding source. It's called The Essential Guide to Non-Emergency Medical Transportation, and it's put together by SwiftAid Transport.
It's a fantastic breakdown.
It really is. And our mission for this deep dive is to completely reframe how you think about medical access, to show you that the journey to the doctor is not, like, separate from the treatment.
It's the very first step of the treatment.
Exactly. We're going to look at how specialized transportation bridges the gap between a person's medical need and the cold, hard reality of getting healthcare. So, okay, let's unpack this, because we throw around terms like medical transportation, and the immediate mental image is, flashing red lights.
Yes, sirens, an ambulance weaving aggressively through traffic.
Right? But before we even talk about who is using this service, we have to establish a hard boundary around what non-emergency medical transportation, or NEMT, actually is and what it isn't.
We have to draw that line because conflating NEMT with emergency services is incredibly dangerous. NEMT is specifically engineered for people who require physical or logistical assistance getting to and from healthcare-related appointments.
But they don't need a paramedic in the back with them.
Exactly.
Yeah.
They absolutely do not require emergency clinical intervention during the ride itself. That's the key distinction.
The source text gives us this definitive 911 rule. Basically, NEMT is not an ambulance, period.
No, it's not.
The Centers for Disease Control and Prevention, the CDC, explicitly warns that conditions like sudden chest pain, severe uncontrolled bleeding, trouble breathing, stroke symptoms, or, a loss of consciousness mandate an immediate 911 call.
You do not call a transit service when you're having a heart attack.
No, because an NEMT vehicle, while highly specialized, is not a mobile emergency room.
Right. NEMT steps in when the medical condition itself is stable, but the transportation represents the barrier to care. And the Centers for Medicare and Medicaid Services, CMS, actually approaches this from a fascinating policy perspective.
Oh, this part was super interesting.
Yeah, they recognize what they call the assurance of transportation as an integrated component of healthcare. So Medicaid specifically carves this out as a benefit for eligible beneficiaries to access covered services.
Wait, hold on. If I'm a taxpayer and I'm hearing that Medicaid is paying for glorified taxi rides, I'm thinking, wow, that sounds incredibly expensive.
Sure, sounds like a luxury.
Right, and honestly ripe for massive systemic waste. How does the math on this actually work out for the healthcare system?
Well, the math is actually heavily in favor of funding the ride. Let's look at the financial realities here. If an individual with a chronic condition misses a $50 routine checkup because they couldn't secure, say, a $30 ride.
Their condition deteriorates.
Exactly. Their condition gets worse. 2 weeks later, they suffer a catastrophic medical event and end up in the emergency room, followed by a week in the ICU.
Oh, wow.
That sequence just cost the healthcare system tens of thousands of dollars. From a sheer systemic design standpoint, spending that $30 on an NEMT ride is the ultimate form of preventative medicine.
That is a wild way to think about it.
The government spends billions funding treatments, right? But if you don't fund the logistical bridge to connect the patient to that facility, all the funding for the treatment becomes a sunk cost.
That drastically changes the perspective. It shifts transportation from being a separate external problem to being a core pillar of the medical budget.
It has to be.
And this ties directly into the core philosophy SwiftAid Transport outlines in their guide. They argue that medical transportation must be treated as part of the care experience, not just a geographical transaction.
Right, because when you use a standard rideshare app, the business model is entirely transactional.
The driver's only mandate is the GPS route from point A to point B. They don't care about anything else.
SwiftAid completely dismantles that transactional model. They break down the NEMT care experience into distinct, non-negotiable elements. You've got safety, mobility, timing, communication, and dignity.
Dignity is a huge one there.
Having the right level of transportation support means the driver is actively calculating all of those variables simultaneously. A standard ride basically asks one very basic binary question.
Can this person get into a car?
Exactly.
The guide points out that this is fundamentally the wrong question to ask. A standard rideshare is essentially a food delivery service for human beings.
That's a great analogy.
Like if you order takeout, the delivery driver's only job is to leave the bag on your porch. They aren't checking if you have the dexterity to open the containers or if you have the right silverware. They drop it and speed off.
Yep. Out of sight, out of mind.
If a standard driver pulls up to the curb and unlocks the doors, the rest is entirely on you. The source text gives us the better question we should be asking.
Which is, can this person safely, reliably, and appropriately get to their healthcare destination without professional transportation support?
Yes. And defining appropriate is where the nuance really lies.
Absolutely. Because a person might technically be able to physically force themselves into a low-riding sedan, but doing so might cause immense pain or exacerbate an injury.
Or just leave them dangerously exhausted before they even reach the waiting room.
Right. NEMT is about removing the physiological and psychological friction from the journey.
So let's look at the actual demographics utilizing this friction removal, because the first group the guide highlights is one that almost everyone listening will eventually encounter.
Older adults.
Yes. Older adults who are slowly and sometimes totally invisibly losing their driving independence. We aren't talking about someone who is bedridden here.
No, we're talking about the ambulatory passenger.
Right.
The term ambulatory simply means the individual can walk. But the guide emphasizes that mobility is not a binary state of either running marathons or using a wheelchair.
Yeah.
There's a massive, complex middle ground.
It's a huge spectrum.
An older adult might be able to walk perfectly fine around their own living room, communicate clearly, manage their own calendar, but put them behind the wheel of a 2-ton machine going 60 miles an hour, and hidden physiological hurdles emerge.
And the National Institute on Aging outlines these physiological changes in stark detail. It's not just a vague concept of, getting old.
No, it is specific, measurable degradation.
Exactly, like macular degeneration or cataracts. Those severely impact night driving, depth perception, and glare recovery.
Plus, you have slower neurological reaction times, and you have the compounding side effects of polypharmacy.
Like taking multiple medications at once.
Right. Maybe they're taking a blood pressure medication that causes mild dizziness, paired with an arthritis medication that slows their physical reflexes.
The resulting behavior is what the text identifies as avoidance. You start hearing things like, oh, I just don't drive at night anymore.
Or, I only take the back roads to avoid the interstate.
Yeah. Or they develop a severe, paralyzing anxiety about traveling alone entirely.
But what happens when the required specialist is located at a massive medical complex right off a busy 8-lane interstate?
And the only available appointment is at 4:30 p.m. in the middle of January when it gets dark super early.
Right. Those avoidance behaviors suddenly metastasize into missed appointments. They just cancel.
And if they do try to find alternative transportation, the options are fraught with immense emotional friction. Like, relying on family means forcing an adult child to burn vacation days or navigate complex work absences.
Which nobody wants to do. Relying on neighbors quickly crosses the line from a favor into feeling like a really heavy burden. And standard rideshares introduce terrifying vulnerabilities.
I try to put myself in the shoes of an 80-year-old navigating this. Imagine you are dropped off at the curb of a massive, sprawling research hospital.
It's incredibly overwhelming.
There are buses, taxis, delivery trucks, and ambulances rushing everywhere. You're highly anxious about the oncology test results you're about to receive. Your knees simply do not move as fast as they used to.
And a standard driver evaluates their success by how fast they can complete the trip and move to the next fare.
Yes. They pull up, they dump you into this chaotic drop-off zone, and they speed away. You are entirely exposed, outpaced, and vulnerable.
That is exactly where the concept of behavioral accessibility becomes crucial. The text references the Americans with Disabilities Act, the ADA.
Which we usually just associate with ramps.
Exactly. It specifically mentions the U.S. Department of Justice's focus on effective communication. We usually relegate the ADA to civic engineering, the width of a doorway, the slope of a concrete ramp, the installation of grab bars.
Right, ramps and physical hardware.
But the DOJ's focus on effective communication implies something much deeper. Accessibility is not merely physical, it is behavioral.
Behavioral accessibility. I love that term.
In the context of NEMT, accessibility means a driver's attitude. It means their rigorous training and patience.
It means their ability to provide clear, steady, step-by-step instructions to a passenger who might be moving slowly, feeling confused by the environment, or experiencing early-stage dementia.
That behavioral accessibility, that ability to de-escalate anxiety and manage pacing, is just as mandated and necessary as a hydraulic wheelchair lift.
You are totally reframing the driver from a steering wheel operator into an active facilitator of ADA compliance. That is an incredible amount of responsibility.
It really is a profession.
But while the aging process presents this gradual creeping mobility challenge, the guide violently shifts gears into a completely different scenario. One where the mobility challenge is sudden, acute, and can happen to absolutely anyone listening to us right now, regardless of whether you're a 25-year-old athlete or a senior citizen.
We are talking about post-surgery recovery.
Post-surgery recovery is the great logistical equalizer. The text is definitive. Patients who are cleared to leave a facility after a procedure often cannot safely drive. The reasons are entirely physiological and inescapable.
Your body has just been subjected to controlled trauma.
I want to dig into those physiological reasons because we casually say anesthesia without thinking about what it actually does to us.
Oh, absolutely. If you've been under general anesthesia or even heavy conscious sedation, your spatial awareness is fundamentally compromised for up to 24 hours.
Your fine motor skills are totally shot.
And you are likely loaded up on opioid pain medications that explicitly forbid operating heavy machinery. You might be dealing with acute vertigo, or you have temporary physical restrictions, your arm is immobilized in a sling, or your leg is entirely numb from a nerve block.
And SwiftAid provides a list of common procedures requiring NEMT that highlights how routine this is. We are not just talking about open heart surgery or organ transplants here.
No, we're talking about orthopedic procedures like a knee arthroscopy, complex wound care, same-day outpatient surgeries.
Endoscopy-related visits like a colonoscopy where the sedation leaves you profoundly groggy.
Here's where it gets really interesting. Think about eye procedures. Cataract surgery is incredibly common.
Imagine this visceral scenario. You just had cataract surgery. Your pupils are medically dilated. You are wearing dark plastic shields taped over your eyes. You have mild sedatives coursing through your system, and it is pouring rain outside.
That sounds like a nightmare.
Now imagine a standard rideshare driver who just wants to clear the queue, drops you off at the wrong entrance of your massive apartment complex, hits complete trip, and drives away.
You aren't just inconvenienced. You are in immediate, severe medical danger.
You cannot see the curbs, you are unsteady on your feet, and you are entirely alone.
Which is a catastrophic failure to follow through on the care plan. The Agency for Healthcare Research and Quality, or AHRQ, dictates rigorous guidelines for patient safety and discharge planning.
Right.
The healthcare facility has done its job perfectly. The surgery was a clinical success. The patient is officially cleared to leave, but they are stepping out of a highly controlled, sterile, monitored environment into the unpredictable chaos of the outside world during their most vulnerable hours.
The instructions almost universally mandate that the patient must have a responsible adult transport them home. You cannot just call a cab.
NEMT acts as that professional, responsible bridge. It provides a driver who is trained to understand that this specific passenger might need a steady arm for balance, extra time to transition from standing to sitting, and absolutely zero rushing.
And the logistical challenge extends far beyond that single ride home from the surgical center. The text brings up the grueling reality of rehabilitation: physical therapy, occupational therapy, speech therapy, cardiac and pulmonary rehab.
The National Institute of Neurological Disorders and Stroke provides a perfect lens for this regarding stroke recovery. You survive the stroke, you spend weeks in the hospital, you're finally discharged.
Thank goodness.
But now you face 6 months of intense, multidisciplinary rehabilitation. You are improving, but your equilibrium is still damaged. You suffer from profound neurofatigue.
You absolutely cannot legally or safely drive a vehicle.
So how do you physically transport yourself to the outpatient facility 3 times a week to do the grueling work that actually gives you your life back.
It transitions us from the sprint of an acute, one-time recovery into what feels like a logistical marathon. A one-time ride is a puzzle you can usually solve by calling in a favor.
But what happens when the healthcare system requires you to run that marathon for years?
Exactly. Let's look at dialysis, chronic illness, and behavioral health because the sheer scale of the transportation need here is staggering.
It is the routine of survival. The National Kidney Foundation explains the mechanics of dialysis, and understanding those mechanics is crucial to understanding the transportation barrier. Dialysis is essentially a machine doing the work of your failed kidneys,
Yeah.
artificially filtering toxins and excess fluid from your
When
blood.
you hear the word dialysis and think of it as just another appointment, but we need to describe what that actually entails. A patient sits in a chair for up to 4 hours.
Their blood is literally being pumped out of their body, run through a dialyzer, and pumped back in.
It causes massive rapid shifts in fluid volume and blood pressure. When a patient finishes a 4-hour session, the physical depletion is profound. They experience what is called a dialysis washout.
They are severely nauseous, their blood pressure might be plummeting, causing acute dizziness, they're cramping, and they're overwhelmingly exhausted.
The text makes a stark, uncompromising point here. Missing a single dialysis treatment creates an immediate, life-threatening health emergency. Toxins build up rapidly. Fluid accumulates in the lungs.
It is not a dental cleaning you can casually reschedule for next Tuesday because your car wouldn't start. Your continued existence depends on being in that specific clinical chair, on schedule, every single week.
So to the skeptic who asks, well, if they can walk out of their house, why can't they just take the city bus to the clinic? I want to look at those physiological facts.
It's just not realistic.
Expecting a profoundly drained patient whose blood pressure is fluctuating wildly to walk half a mile to a bus stop, stand in the freezing wind, navigate a complex public transit schedule, and endure a bumpy, unyielding ride surrounded by strangers is a fundamental failure of basic human care.
It ignores the physiological reality of the disease entirely. The CDC defines chronic diseases, such as heart disease, cancer, and diabetes, as conditions that last a year or more and require ongoing medical attention or limit activities of daily living. That limitation is the key metric.
When the SwiftAid guide discusses recurring treatments like chemotherapy or radiation, the central theme that emerges is a brilliant distinction between two concepts: availability versus reliability.
It is a vital distinction. Availability means there is theoretically a vehicle somewhere in the metropolitan area that could eventually pick you up. A taxi is available. A bus is available.
But reliability is different.
Reliability, in the NEMT context, means a highly trained professional will be at your door at exactly 6:00 a.m. without fail, because your treatment protocol requires it.
For recurring care, punctuality, precise scheduling, and trip documentation are not just good customer service practices, they are medically necessary protocols.
A patient fighting stage 3 oncology treatments should be focusing every ounce of their limited metabolic energy on cellular healing.
They cannot be sitting by their front window, staring down the street, burning cortisol, heart racing, wondering if their ride is going to show up or if they are going to miss their chemo window.
The psychological toll of unreliable transit actively harms the patient's recovery.
That requirement for reliability and profound respect extends deeply into the behavioral health sphere as well. The guide references the Substance Abuse and Mental Health Services Administration, SAM-HSI, regarding access to therapy, psychiatric care, and substance use recovery services.
This is an area where the barriers aren't necessarily the physical exhaustion we see with chemotherapy, but the logistical friction is just as dangerous.
The friction here is environmental and psychological.
The guide emphasizes that passengers seeking behavioral health treatment require a highly specific transit environment. They need absolute privacy. They need consistency.
They need respectful, trauma-informed communication from a driver who doesn't pry, judge, or ask intrusive questions.
Ensuring an individual can consistently get to an intensive outpatient addiction recovery meeting or a critical psychiatric medication management appointment is foundational to their continued survival and stability. NEMT provides a dignified, secure, and private logistical space to make that happen.
Transportation really emerges as a lifeline. But what happens when that lifeline snaps? If we pivot our focus away from the patient for a moment, the guide spends a significant amount of time analyzing the collateral damage.
When a patient cannot secure a reliable ride, who absorbs the shockwaves of that failure?
The collateral damage falls squarely on caregivers and the healthcare facilities themselves. They bear the crushing weight of this systemic failure.
Let's examine the caregiver side first, because the data reference from the Family Caregiver Alliance is deeply sobering. Families carry an immense, often invisible, emotional and logistical weight.
We talked earlier about the guilt an older adult feels when asking for a ride, but flip the lens to the caregiver.
You're a 40-year-old trying to hold down a demanding full-time job, you're raising your own children, and now you have to negotiate with your boss to take off work every Tuesday and Thursday at 2 p.m. to drive your father across town for specialized wound care.
It is a completely unsustainable model for the modern working family, and the text highlights that the burden goes far beyond just the time commitment or lost wages.
It is an acute physical and psychological strain. A caregiver with zero medical training is suddenly tasked with physically lifting a passenger who might have severe balance issues.
They are wrestling a heavy, awkward wheelchair into the trunk of a standard sedan in the pouring rain. They are desperately trying to manage complex clinical communications with the facility staff while exhausted.
They are essentially being forced to act as amateur, unpaid medical transport drivers, but without any of the specialized training, the engineered equipment, or the institutional support.
The stress must be suffocating. Reading this, it hit me that professional NEMT allows a profound restoration of roles. It allows a son or a daughter to just go back to being a loving family member.
They can drive themselves to the clinic, meet their dad there, hold his hand in the waiting room, and be fully present to listen to the doctor's prognosis without being physically wrecked and emotionally fried from having to orchestrate the transport.
Preserving that family dynamic is a massive secondary benefit. But if we connect this to the bigger picture, the ripple effect of broken transportation doesn't stop at the family unit.
No, it is the entire system.
The guide outlines how fundamentally reliant healthcare facilities themselves, hospitals, rehab centers, dialysis clinics, are on external logistics.
The hospital is fundamentally a pipeline. It operates on strict principles of intake and outflow.
That is the exact mechanistic analogy we need. A hospital operates a finite number of beds.
The text makes it explicitly clear that when transportation fails, the facility's entire workflow gridlocks. Imagine a major hospital where 4 patients are medically cleared for discharge by 10:00 a.m.
Their charts are closed.
But their family member's cars broke down, or the local taxi service refused to take a patient who requires a walker and oxygen.
The exit valve is blocked. Those patients cannot physically leave the building.
They cannot leave, which means they continue to occupy those 4 beds for another 6, 8, maybe 12 hours. Now, zoom out to the emergency room at the front of the hospital.
Right, where people are waiting.
There are critically ill patients waiting in the ER who desperately need to be admitted to those exact beds. But the beds are occupied by completely healthy people who simply lack a ride home.
The pressure backs up all the way to the intake valve. A delayed discharge because of a broken transmission on a family minivan literally causes a systemic backup that prevents a sick patient from entering the hospital.
The guide mentions frustrated families and extra staff workload. But when you map the mechanics of it, NEMT isn't just a taxi service for patients.
It is a critical workflow solution for hospital administrators. It manages the supply chain of available medical beds.
The coordination of discharges, the complex transfers between an acute care hospital and a skilled nursing facility, the management of recurring appointments facilities are utterly dependent on highly dependable transportation partners because their internal clinical efficiency is entirely held hostage by external logistical realities.
To solve that logistical pipeline puzzle, you need the right engineered tools. The guide gets very granular about the fact that standard consumer vehicles simply do not cut it for a massive portion of these patients.
We have to look far beyond the standard sedan and explore the engineering of wheelchairs, stretchers, and pure mechanical reliability.
Before we get into the heavy engineering, we should acknowledge a specific demographic the guide explicitly names: the No Reliable Transportation Group.
The New York State Department of Health and Medical Answering Services provides significant data on this population. These are individuals who might not have a severe illness or any visible physical disability at all.
Right, they simply exist in a logistical desert. They don't own a car, perhaps for financial reasons. They live alone.
They reside in a rural area miles away from the nearest clinic or in an urban neighborhood where public transit infrastructure is functionally non-existent.
If the nearest bus stop requires a mile-long walk across intersections with no crosswalks, the physical vehicle is the barrier.
But for those who do present with visible mobility challenges, the vehicle requirements shift from mere availability to highly specialized engineering. Let's discuss wheelchair transportation, because the text works very hard to dismantle a huge public misconception.
Yes, the DIY approach. People think, oh, I'll just buy a foldable metal ramp, bolt it to the back of my old minivan, and suddenly I'm running a medical transport business.
That is horrifyingly incorrect and incredibly dangerous. ADA compliance for wheelchair transport involves a rigorous, scientifically tested set of standards.
It's not just about getting the chair into the vehicle.
It's about what happens when that vehicle is moving at highway speeds. It requires proper, engineered multi-point securement systems, often a 4-point tie-down system that anchors the frame of the wheelchair directly into reinforced tracks in the floor of the van.
It requires specialized lap and shoulder belts designed specifically for seated passengers so they don't submarine under the belt in a collision.
It requires an understanding of physics. The suspension of the van has to be modified to handle the uneven weight distribution, and the driver training is intense.
The driver must know exactly how to operate hydraulic lifts manually if the power fails. They must know how to load and unload on an incline without tipping a heavy power chair backwards.
And crucially, they must know how to communicate constantly with the passenger during the entire loading process to avoid startling them.
There is a quote in the SwiftAid guide that I think is the most powerful sentence in the entire document. It states, "A wheelchair passenger should never feel like cargo."
It is a profound articulation of basic human dignity.
It really is. Because if you just roll a human being into the back of a dark, windowless van, strap their chair down in silence, ignore them, and hit the gas.
You're treating them like a pallet of industrial goods.
Exactly. The care experience demands that the physical environment of the vehicle, the attitude of the driver, and the entire loading process reflect the fact that they are a human being receiving support.
And that level of specialized engineered support escalates even further when the guide transitions to discussing stretcher transportation. This is an area where the distinction between NEMT and an emergency ambulance requires very careful, precise navigation.
This is a major point of confusion I wanted to drill down on. If I am a family member and my mother cannot sit up in a wheelchair due to a severe back issue, my immediate panic instinct is, we have to call a 911 ambulance.
Of course it is.
How does a family know whether to order an NEMT stretcher van or a full-blown advanced life support ambulance?
It all comes down to two factors: medical necessity and clinical stability. The guide uses Medicare's stringent coverage rules to explain the dividing line.
Okay, lay that out for us.
NEMT stretcher transport is specifically engineered for patients who are definitively medically stable, meaning their vitals are not fluctuating, they're not in acute distress, but for strictly physiological or structural reasons, they cannot safely or comfortably sit upright for the duration of the ride.
Give me an example of what that looks like in practice.
Imagine a patient recovering from a complex spinal fusion surgery, or someone with severe generalized weakness from advanced age, or a patient with a specific post-surgical restriction that forbids bending at the waist. They must remain lying entirely flat.
Okay, so they are medically stable, but structurally they must lie down.
Correct. But, and this is the absolute red line, if that exact same patient requires active oxygen management by a respiratory therapist, if they need their vital signs continuously monitored on an EKG screen,
Or an IV drip, right?
exactly, if they have an active IV drip that requires clinical intervention, or if there is any reasonable chance their airway might become compromised during the transport, that requires an ambulance.
Medicare policy explicitly states that an ambulance is covered only when transportation by any other vehicle could endanger the person's health.
The NEMT stretcher option represents this incredibly vital, cost-saving middle ground. It saves the family and the healthcare system the astronomical thousands of dollars cost of an ambulance deployment.
And critically, it frees up that highly equipped ambulance to be available for an actual life or death 911 emergency in the community, while still providing a safe, perfectly flat, secure transport for someone who just structurally cannot sit in a wheelchair.
It is the ultimate example of matching the exact transportation modality to the passenger's actual clinical condition. Which brings us to the final, most practical puzzle piece the guide offers.
We've discussed all these options: ambulatory pacing, ADA wheelchair securement, flat stretcher transport. But how do overwhelmed families, busy case managers, or stressed hospital discharge planners actually synthesize all this information and make the correct call?
It is incredibly overwhelming. You're stressed, your loved one is sick, the hospital is pressuring you to vacate the bed, and now you have to suddenly become an expert in medical logistics and vehicle engineering.
But the SwiftAid guide provides a remarkably practical evaluation checklist. It is essentially an operational framework to determine exactly if NEMT is the right choice, and just as importantly, when it is the wrong choice.
We must always start with the contraindications. The text is definitive on when NEMT is absolutely inappropriate. We have established this, but it must be repeated. Active emergencies.
Severe bleeding, stroke, chest pain, call 911.
Call 911. But moving past acute emergencies, NEMT is also inappropriate if the passenger requires any active continuous medical care during the transport itself.
If their overarching condition is deemed unstable by their attending physicians, or if they cannot be transported safely using the available vehicle restraints.
But if I play devil's advocate here, how do families avoid making dangerous, potentially fatal mistakes in this assessment?
Right, if you aren't a doctor, how are you supposed to know the clinical definition of unstable?
The guide anticipates that exact anxiety and offers a golden rule. When in doubt, default to the experts. Ask the medical professionals directly what level of transportation is appropriate.
Families should never feel like they have to consult Google to guess their loved one's stability.
Ask the discharge nurse. Consult the attending physician. They are trained to tell you definitively if the patient requires an ambulance with paramedics or if a standard NEMT wheelchair van is perfectly safe.
That immediately strips so much pressure off the family. Just ask the clinical staff. And once you have that confirmation that they are medically stable, the guide offers a checklist of highly practical questions to dial in exactly what tier of NEMT you need.
Let's run through this framework because this is highly actionable for anyone listening who might be actively navigating this maze for an aging parent right now.
So what does this all mean in practice?
The first tier of questions assesses the passenger's physical capability. Can the passenger safely walk to the vehicle? Can they physically sit upright for the entire duration of the ride?
If the answer to sitting upright is no, you immediately route to stretcher transport. If yes, you move to the next variable.
The next variable is equipment. Does the passenger utilize a mobility aid? Are they in a manual wheelchair, a heavy bariatric power chair, a walker, or using a cane?
Do they require physical hands-on assistance transferring from their house into the vehicle?
That delineates whether you need a standard ambulatory vehicle with a driver trained in pacing or a specially equipped van with a hydraulic lift and 4-point tie-downs.
Then you assess the logistical nature of the trip itself. Is it strictly for a healthcare-related appointment or a post-surgical hospital discharge?
And does the passenger require recurring high-frequency transportation, like the grueling schedule we discussed with dialysis or chemotherapy?
And finally, the environmental and safety questions. Is there a caregiver or a facility coordinator involved in organizing this?
And critically, would utilizing a regular consumer car, a standard taxi, or a rideshare app create safety hazards, timing failures, or accessibility nightmares?
If the answer to that final question is yes, if a standard taxi introduces a safety or timing risk, then specialized NEMT is the definitively appropriate choice.
It is a brilliant, simple distillation of an otherwise incredibly complex, high-stakes logistical challenge.
It takes all the raw emotion, the guilt, and the panic out of the decision-making process and converts it into a clean, operational checklist.
And that checklist ultimately points directly back to the core unifying message that SwiftAid Transport communicates throughout this entire comprehensive guide.
Which brings us to the final summary. The realization that needing non-emergency medical transportation is not about accepting a label of being sick, weak, or unable to care for yourself.
It is simply recognizing that the physical transportation is an undeniable, structural, and heavily engineered part of actual healthcare access.
NEMT provides a transportation experience that actively respects and accommodates the medical reality, rather than ignoring it and hoping for the best.
It systemically removes the physical and psychological friction from the journey, allowing the patient to preserve their energy and focus entirely on the ultimate destination healing.
If you are listening to this and realizing that you, a family member, or perhaps the healthcare facility you work for requires this kind of highly specialized logistical support, the guide provides their direct contact infrastructure.
You can reach out with specific coordination questions at support@swiftaidtransport.com or explore their services at www.swiftaidtransport.com.
Before we close out this deep dive, synthesizing all of this source material, particularly the recurring insistence that transportation is fundamentally integrated into the medical care experience, leaves me contemplating a rather provocative extrapolation.
I always love these. Where does this lead us?
Well, if the Centers for Medicare and Medicaid Services officially recognize, via funding, that a lack of transportation literally prevents human beings from receiving life-saving healthcare, how radically might the physical design of our future cities change if we started viewing all public infrastructure, from the routing of bus lines to the precise width and smoothness of our sidewalks, not just as matters of civic engineering or urban planning, but as baseline, preventative medical care?
If the journey itself is healthcare, then every crack in the pavement, every missing crosswalk, and every delay in a bus is a literal medical barrier.
That completely shatters how you look at a city street. It's not just poured concrete, it is the very first leg of a medical journey. A broken sidewalk is a broken healthcare system. I want you to mull that profound idea over the next time you are driving and you see a specialized NEMT wheelchair van in the lane next to you. Remember the engineering, the training, and the care inside that vehicle. That is not just a van. That is the invisible bridge making the cure possible. Thanks for taking this deep dive with us. We will catch you on the next one.